Hello, my name is Andrey Shental, and I'm curating the discussion series for Moscow Biennale for Young Art. The program at hand is provocatively or pretentiously titled Salon of Rejected Categories, which means similarly to the French Salon in the 19th century of the refused artists, it stays in a kind of opposition to the main project of Young Biennale. We have made a short but very productive journey starting from discussion of aging and senior age. And I think it was a unique discussion in contemporary art context, at least in Russia. So you can check all other events, they were recorded, some of them already online. And tonight we are finally arriving at our last panel. And I'm really excited about this event, especially because of the wonderful speakers, but also because of the subject of the discussion. I called it Splendor and Misery of Illness, which probably is not the best title, but at the same time, it points to certain basic contradictions that, in my view, lie behind this category of illness. And illness is something that affects us on our daily basis. It affects everybody. But nevertheless, if you look at art or even at philosophy, we do not see so many reflections. Of course, one could object that there are many works on death. There are some works on mental illness. I could also recall many works on certain terminal illnesses like AIDS or cancer in art, for instance, like Sophie Calle or Felix Gonzalez Torres. There is also discourse on disability, and in art context, it's usually called inclusivity, which is something also maybe separated, not fully integrated in the discussion. And suddenly, so the idea of illness is often taken as something that comes and goes or something inevitable. Probably because of that, it's not that reflected. And suddenly in this year, as we all know, everyone started to talk about that. As everyone became alert to his, to her, or their personal experience of health. But I'm interested personally in this subject, not only because of pandemic, but because it shows us many fundamental contradictions and conflicts that, that belong to human existence, to social body, and to visual culture. And dramaturgy or plot line of tonight's event would follow and untangle these three basic contradictions. And I would quickly explain them. And through this, I would introduce also participants' papers for tonight. Probably they go slightly in different directions. So I would start with experiential dimension, as it's quite clear, even from the coronavirus situation, different attempts to pinpoint, to pigeonhole, or to classify diseases sometimes go against personal symptoms and personal experience of disease. For instance, I guess I personally have at the moment coronavirus, but I feel taste, I feel smell, and I'm not sure it's the most common experience. And in philosophy, in Russian context, it's well known as in her name, Anne-Marie Moll, because her book was translated and she gave interview and so on. And she spoke that her basic idea is that body is no longer one body, it's always a multiple body. For instance, if you have a problem with your hand and you go to a hospital, in different departments of a hospital, there would be different diagnoses for the same issue. And also, it also shows a fundamental split from the worldview of a doctor and these medical protocols of description of disease and the personal experience. So in her paper, Havi Carel is going to tackle this dualism of phenomenology and physiology, or naturalist account of disease and illness, and she differentiates. And I quickly go to the second point. We also have a common view that illness affects everybody regardless of their status, So we also susceptible to it. And it is sometimes called kind of equalizer. But at the same time, we know from history and that different diseases were, especially if you go back to feudal times and maybe to early capitalist time, some of the diseases were perceived as a kind of, they were stigmatized as belonging to poor people because they lived in some non-sanitary, non-hygiene environment. And some diseases, on the contrary, were attributed in mass consciousness to rich people. It was like a curse to rich who kind of decadent or whatever because they had access to particular lifestyle. For instance, we could speak about, in Russia it's called podagra, I think in English it's gout, G-O-U-T. And therefore also we have another problem that some diseases become, I'm afraid is this term, but sometimes like fashionable. So some people idealize them and romanticize them. And some diseases get stigmatized and not discussed. And some diseases get certain political resonance. And this inequity, this inequality and socio-political history of illness would be discussed by Anna Mazanik tonight. Do I pronounce your surname correct?
Mazzanik.
Mazanik, sorry.
No problem.
And finally, illness could be viewed also as a manifestation of this fundamental philosophical difference between virtual and actual. So virtual is something, I mean, it's like something like a digital code, something that has potential to be realized, to be manifested, but could be not realized, for instance. When we speak about illness and art, it also reveals certain problems and certain contradictions. For instance, it's very, because certain illnesses, they have very vivid manifestations. They got prominence, they were popular among artists to paint them. Of course, they contradict the idea of beauty or whatever, but in 20th century, there were produced special categories like uncanny by Freud, traumatic, there was like whole trauma art in the 1980s, or abject art by Yulia Kristeva, and some others. But also there are certain diseases like AIDS, HIV, or certain other viruses that are not representable. And also there is a big question, how would we represent pain? How would we manifest pain by means of purely visual means? And these questions would be explored by Lera Kononchuk in her paper. So finally, I would like to introduce Havi Carel, who is a professor of philosophy at the University of Bristol. She recently completed a Wellcome Trust Senior Investigator Award, The Life of Breath. Her third monograph, Phenomenology of Illness, was published by Oxford University Press. Also, Havi is author of Illness, shortlisted for the Wellcome Trust Book Prize, and Life and Death in Freud and Heidegger. She is a co-editor of Health, Illness and Disease, New Takes in Film Philosophy, and of What Philosophy Is. So the floor is yours.
Thank you very much, Andrei. And hi, everyone. I'm really delighted to take part in this event. It's not often that I have a chance to communicate with people who are artists and people interested in art, and I'm really delighted to be able to take part. So I'm going to be speaking on the topic that Andrei's outlined already. And Andrei, just I'm checking, I've got about 20 minutes.
Yes, 15, 20, but if you go slightly more, it's like, okay.
Okay, I'll try not to. So I'm going to now share my screen with you and use the slideshow, hopefully, to to guide you through some basic overview of the phenomenology of illness. So as Andrey was saying, there's a big gap between the experience of illness and what we might call the underlying physiological or biological disease, and the way in which the physiological process of disease gets experienced by people. But these are two very, very different things, and I'll try and illustrate that in the talk. Now, you might ask yourself, why does a philosopher want to think about illness? What's so philosophical about illness? So I want to just start out by talking about the philosophical core of the experience of illness and why I think it's so important for humans in general to reflect on it. So of course, if you think about it, being ill is a near universal experience, not in the sense that everybody's ill at the same time, but that if you look at a human being over a lifetime, then everybody experiences illness of some sort at some point in life. And despite the fact that it's such a nearly a universal experience, it's very poorly understood. So here's some examples for questions we might ask ourselves. We might ask, what is the relationship between health and, of course, its absence and well-being? Or in other words, does the absence of health necessarily mean that one is going to be unhappy? Is it possible to be ill and flourish in the Aristotelian sense, or in other senses of the word flourishing? What aspects of the ill person's life are impacted by illness? What happens to the ill person's social world? How does one's self-understanding change when they fall ill or when their illness becomes worse? So all of those kinds of questions are ones that have a philosophical underpinning. And there's one more really important thing, which is that when we fall ill, when there are changes to the ways in which we experience our bodies, that of course can also illuminate how our bodies are experienced by us in cases when everything is going fine or when we're healthy. So for example, right now we're all sitting, I assume, on a chair, feeling pain-free, feeling comfortable. And of course, if something goes wrong in the body, if you're hungry all of a sudden, or you get dizzy, or you feel nauseous, then all of a sudden that whole taken for granted, or if you like, transparent aspect of our experience can come to the fore. And it is what happens when the body comes to the fore that I think is very, very interesting, philosophically, of course, phenomenologically, and has taken up not enough space in philosophy, given the significance and the centrality of that experience. So, of course, illness has many painful aspects. That could be physical pain, psychological pain, spiritual pain, and of course, understanding the experience of illness in the terms I'm about to propose to you using phenomenology can really help us also in the practical sense, that we can then go back to physicians and say, okay, these are the things that really trouble people who are ill. What can you do to alleviate these painful aspects? So going back to the distinction I mentioned a minute ago, what I think is really useful is distinguishing between disease, which is the dysfunction of the biological body, so the physiological lesion or problem that is giving rise to the disease, and then the illness experience, which is the way in which we experience that biological process. And you can think about illness phenomenologically as a disruption of the lived body, the disruption of my body as I normally live it. And of course, we know from phenomenology, and I'll give an example in a minute, that when we change your physical possibility, we don't just change how you can move around in the world, how fast you can run, how far you can go, but you also transform a person's subjectivity in very profound ways. And we really need first-person accounts of illness of the sort we're seeing, for example, in Frida Kahlo's piece that we're looking at in the slide, in order to understand how that transformation of possibility changes who you are as a person, how you are in the world, how you are with other people you're being with, and so on. So phenomenology can help us because its purpose as a philosophical method is to describe invariant or essential structures of experience. And I like this example from Pierre Bonnard's famous painting, The Bath, as a depiction of depression. So this is a painting he made of his wife who was melancholic or depressed and was prescribed this hydrotherapy, lying in a bath for up to 10 hours a day. And if you look at the image, you can see that he was really trying to capture the passivity of the body, maybe the giving up of the person on movement and on agility and on motility. And at the same time, also the way in which the body is restricted, is contained within the bath, within the wall tiles, within the water. So what phenomenology can be useful for is to help us illuminate the quality of these kinds of subjective experiences. And of course, the personal meaning, or the way they are understood by other people, by the people, who live them. And of course, also their pattern and coherence over time. So what we're looking for when we think about a phenomenology of illness is really a way of asking how people, individuals who are ill, experience their disorder, rather than thinking pragmatically or empirically, saying, okay, so what's the problem? How do we solve it? What's the issue? How do we respond to it? In the case of a phenomenology of illness, you first of all want to understand how people experience their disorder. And of course, to view that disorder as something that is embodied, that is experienced in the body, that is enacted, that is experienced through actions and the ways in which a person moves around and lives in the world. And of course, they're situated, and that means located in the particular cultural and historical period and the particular life circumstances of the ill person. So the question a phenomenologist of illness might ask is, how are such embodied states lived as meaningful in a particular environment? And I'm giving here as an example a still from Julian Schnabel's film, The Diving Bell and the Butterfly, which tells the story of Jean-Dominique Bobby, who suffered from locked-in syndrome. So he was paralyzed in his entire body with the exception of his left eyelid. So he went within the space of minutes from being a healthy, able-bodied man at the prime of his life to being completely trapped inside a body and only able to communicate by blinking his left eyelid. So what happens to a person when their bodies change in such a radical way? How is that a meaningful transformation, and how are these embodied states understood by the ill person? So those are the kinds of questions you might ask in phenomenology. And here we've got a contrast, a very strong contrast between another still from the film. So this at the bottom, we're seeing an image of the diving bell and the butterfly again. And what we're seeing in this scene is that Jean-Dominique Bobby's girlfriend is breaking up with him on the phone. And what he really wants to do is shout and say, well, you know, that's fine with me, I don't care. But he's completely trapped in the body, in his paralyzed, locked-in body. And he's only able to kind of blink, and the nurse is translating in a very slow, painstaking way, translating back to the girlfriend. And it's a very heart-rendering scene because it shows us how motility and speech are so absolutely fundamental to somebody's being in the world. And of course, that's a nice, there's a nice contrast between that image and the top one, which is of a dancer in a Pina Bausch piece. And of course, when we look at the contrast between these two, we can see exactly what is meant by thinking about the ill person as a being in the world, and how that being in the world can be so curtailed, can go from being one of potential, of possibility, of action, of pursuing one's goals, to being one of disability, inaction, and lack of attunement with one's environment. So illness, again, is just this complete and utter disruption of one's lived experience. Going back to another very powerful Frida Kahlo image, I think what we're seeing in this image is a really beautiful illustration of the way in which we can think about illness as a really broad transformation or redefinition of our relationship to the world. So we can see how the physical world changes, how, you know, your access maybe to places and services can become really restricted in illness, how psychological transformation is there from one of possibility, positivity, ability to one of maybe a sense of deep loss and profound grief, the way in which your social world changes, and in the way, of course, you have to make temporal adjustments to the fact that your life may not be as long as you wanted, and that death is not some faraway event that will happen one day in the future, but is something that one needs to reckon with in the present. So there is a lot of loss in the phenomenology of illness, a loss of agency, a loss of social participation, of productive function, and I'll come back to that in a minute. But another interesting thing I think that might be useful to mention here is that illness can also be seen as a limit case of embodiment. So if we think about Jean-Dominique Bauby, this instance of locked-in syndrome is just an experience of a body that could not be more limited without dying. So this liminal kind of existence where all the things that we take for granted, again, our ability to communicate, our ability to move around, our ability to intuitively move towards our goals, to try and reach out for, you know, some object we're interested in or something we want to achieve, all of that can be really curtailed by the sense of illness as a limit case, a case in which the body has been radically transformed. And of course, what illness also does is it can act as a kind of mechanism for distancing us from our life as it was in the past. Because what we're doing is moving away from all the obvious, transparent, familiar, taken for granted ways of living onto a sense of distance from ourselves, of asking ourselves, why have I lived as I have up until now? Why is my life this way? Okay, and I want in the next 7 minutes or so to just very briefly present 4 phenomenological accounts of illness to show you how they might play themselves out in particular definitions. So the first is that of illness as disability. And what it entails is moving away from understanding our existence as ability, as possibility in the Heideggerian sense, of saying, I am able to, I can do this. If I want to be a skydiver, I can just go on and be a skydiver. To then thinking about the ways in which possibility isn't just an existential category, but has to be cashed out in terms of an ability to perform actions in the world. So if all of a sudden I can't perform an action in the world anymore, then the possibility of being a skydiver has been taken away from me. And of course, this has been taken up by Iris Marion Young in her famous essay, Throwing Like a Girl, where she says, consider the ways in which society and culture restrict our bodily capacities in ways that really impact on our motility, our comportment, and our sense of space. So Marion Young says, compare these two people throwing a ball. And of course, the ball of the guy is going to go much, much further than the ball thrown by the woman. And she says this is not because women are biologically or evolutionarily selected to be weaker or have less muscle or throw less far. It's simply because the ways in which women have been expected in traditional gender roles to exercise and perform their embodiment is that way, the way that is throwing like a girl. So there's nothing given or genetic about these two ways of throwing. These are just expressions of, in this instance, of sexism and the way in which it restricts women's movement, literally. So we can think from that to the analogy of thinking about what it is like to have a body that is restricted, that has possibilities taken away from it in particular ways. The second model is that of illness as a breakdown, where you might think about something like Heidegger's tool analysis. So Heidegger says, well, the nice thing about tools is that most of the time they are inconspicuous. We don't notice them. So when you get into your car to drive to the cinema to watch a movie, when you're driving, you don't think about the car, you think about the movie you're about to watch. Similarly, now we're all using Zoom. We're not thinking about Zoom, we're thinking about philosophy and art or ideas. And what Heidegger's tool analysis tells us is that the tool breakdown, it's when the tool ceases to work that we suddenly turn our attention to it in in a serious way. So then it is when the car breaks down that it becomes conspicuous, to use Heidegger's term. Now, of course, what we can do is draw this analogy and say, okay, so a healthy body is a bit like the car that works. It just does what we expect it to, and in that sense is just sort of transparent. We use the body, you know, to negotiate our environment, to get things done, to do enjoyable things, to pursue our goals and so on. But we don't necessarily stop and think about the body as an object of our intentional reflections in normal cases. But what happens in illness is that the body, of course, becomes conspicuous. And that conspicuousness is one that can make us be more attentive to the case, this description of illness as a breakdown. The third is a definition of illness as being a form of being not at home, or the ill body as being unhome-like being in the world. And this is taken from the contemporary Swedish philosopher Friedrich Svinius, who suggests that illness can be seen phenomenologically as a state of disorientation, of feeling lost. And therefore, the role of medicine is, if you like, to provide a way home for us. And then the final example, the final model I want to present comes from the philosopher S.K. Toombs, who writes about the essential characteristics of illness. So what she says is that illness has essential features that transcend particular features of different diseases. So it doesn't matter if we're talking about diabetes or kidney failure or the common cold. What is interesting is to look at the common features of all of these different diseases. And these common or essential features constitute the meaning of illness as lived. And this is Kay, and here are the essential features of illness that she presents. She says, illness is characterized by 5 losses: the loss of wholeness, the loss of certainty, loss of control, loss of freedom to act, and loss of the familiar world. And there's lots more to be said about this, but I will maybe leave that for the discussion. So finally, we're left with a question posed by the disability activist Harriet Johnson. Does this illness necessarily make us more unhappy? Going back to the question I started out with. And here is what she says. She says, are we worse off? I don't think so. For those of us with congenital conditions, disability shapes all we are. Those disabled later in life adapt. We take constraints that no one would choose and build rich and satisfying lives within them. And I think in a way that's the most important message, the idea that the outsider perspective, which can be one of pity, of disgust, of thinking, thank goodness it's not me, is not really the definitive perspective when it comes to illness, but rather it's asking the person who is living the condition on the inside, so the insider perspective, if you like, where somebody might say, well, yes, I never would have chosen these constraints of having a disability or an illness, but look, I've still managed to build a rich and satisfying life within those constraints, and how important that is and how underappreciated that is. So to conclude, what the phenomenological approach is concerned to show, says Kay Toombs, is not simply that the patient's experience should be taken into account as a subjective accounting of an abstract objective reality, but that the patient's experiencing must be taken into account because such lived experience represents the reality of the patient's illness. So thank you very much for listening. I'm very happy to pick up on any or all of these aspects in the Q&A. This is a list of some of the publications that I was drawing on in this talk. I'm happy to send PDFs of any of these to people. Just drop me an email and I'll happily send you a PDF of the relevant article. And I look forward to the discussion. So this was a really whistle-stop tour of a phenomenology of illness. And thank you very much for listening. I'm looking forward to hearing the other speakers' contributions into a fruitful discussion. Thank you.
Thank you very much. And I would like to introduce our second speaker, who is Anna Mazanik. She is a historian and assistant professor at the Department of Ethics and History of Medicine at Medical University of Vienna. In 2016-18, she curated Russian language collections and the Open Society archives, and in 1920, directed the doctoral program in Environment and Society at the Rachel Carson Center in Munich. Her doctoral dissertation on history of public health in Moscow is coming out as a book, Germs of Change, Public Health and Environment in Imperial Moscow.
Thank you very much, Andrey. Thank you very much to all the organizers of this event. I'm very happy to be here and feeling really privileged to speak after Havi Carel, who made such a wonderful presentation and introduced this kind of tension between the biological definition of illness and the lived experience, individual's lived experience. But I want to push our discussion in a somewhat different direction, meaning from the individual experience to the social response. And so one of the questions kind of with which I started preparing my talk was, why do some diseases get more social attention and greater social response than others? So I have prepared the 6 points that would be kind of around which my talk today would be structured. And I professionally mostly deal with the history of infectious disease. So I will try to provide illustrations to my main points using my historical experience with certain infectious diseases, especially tuberculosis and cholera, that were both conceived as classical diseases of the 19th century and have generated enormous amount of historical literature, which of course makes them a very easy target of analysis here. And as we will see today, they were very different. And I think by kind of contrasting them, one could understand how various patterns that determine this difference in social resonance work. So I would like to start by saying that each disease has a biological and a social reality. On the one hand, it's connected to pain or impairment of function, but it is also a generation-specific kind of repertoire of conceptual and verbal constructs reflecting medicine's intellectual and institutional history. It's an element of doctor-patient interactions. It's an occasion for public policy. It's an aspect of individual identities and cultural values. And this biological and social reality often overlap, but not necessarily, because we know of diseases that already existed and people experienced them, but they were not yet described and perceived as such by the medical community. At the same time, there were also diseases there were human conditions and behaviors that were conceptualized as diseases and described historically as diseases, for example, hysteria or homosexuality, although the somatic basis, of course, remains unclear or non-existent. So one has to be careful in historicizing these connections between the biological and the social reality of disease. But still, the first point that I would like to make is that one has to try to find this connection and look also at disease as a biological reality, because this biology, it does not explain and determine everything, but it often shapes the variety of choices that are available to a specific society when framing the conceptual and institutional response to disease. So here, the questions that one could ask is it infectious? Is it epidemic or endemic? What kind of symptoms does it cause? Is it a chronic disease or acute? Is it how quickly does it kill the patients, or how quickly does it kill them? So if we think of these two diseases that I chose for today's presentation, you will see how dramatically different they are. So tuberculosis is a chronic disease, and people suffering from tuberculosis could live for many years, and kind of it affects their lived experience. While cholera is an epidemic disease. It comes in waves, and it is a very fast killer. You would be can be healthy today and sick and dead tomorrow. So not only sick, but really dead. So it is really, the course is often limited to a couple of days. The symptoms include severe vomiting and diarrhea and severe dehydration. But what it means to society is that with cholera, for instance, people have to, so either they recover or they die, while a chronic disease presents a like burden to an individual and to a society for several, possibly for several years or several decades. And then cholera was very much a disease of the 19th century. The first pandemic that touched Europe appeared only in the 1830s. So for Russian speakers and people familiar with Russian culture in the audience, a good reference point is the so-called Boldinskaya Osin, so the Boldina autumn, the particularly productive period in the literary life of great Russian poet Alexander Pushkin, who then, like, I think that many people here could relate to. So this is exactly the very, very first encounter with this major epidemic disease. So why I mention this is that cholera was, because of its dramatic epidemics, it produced really visible social and political responses, more visible than, for example, tuberculosis, which, although it killed much more people. So according to the like a Russian Society for the Study of Tuberculosis at the end of the 19th century, each year 350,000 people were dying from tuberculosis, but cholera killed, like, once in 20 years about 300,000. So this is a really significantly smaller mortality, but because it all comes together, and because of its epidemic character, and because of its very specific combination of symptoms, it produces different responses. So the second point that I would like to make is the importance of the sociology of disease. And because each disease has a unique configuration of this kind of social characteristics that then trigger disease-specific responses. So whom does the disease affect? Men or women, young or old, white or black, rural or urban, rich or poor. Or rather, because most diseases affect the poor, it often comes to a somewhat different question, which is, does the disease also affect the wealthy and the privileged, in addition to just the poor and the nameless? So, and here we could also think of the category of the idea of the categories that one could easily ascribe to the affected groups. So can one somehow delineate these groups in an easy way that everybody could understand? For example, it's only the black, or only the old, or only the poor, only homosexuals. This kind of stigmatization, which is a process of making really scary things less frightening. You know, it's a way of protecting oneself from the scary disease by saying that it's them, not me. As soon as you kind of put the sick people in the box, it helps you to think that you are somehow better and you could be protected. So this is, we could really see how the stigmatization goes together with a sociology of disease. So if we think of these examples that I brought with tuberculosis and cholera, cholera was primarily the disease of the poor, especially so towards the end of the 19th century, when its connection to, it's a waterborne disease, so that is spread through poor sanitation and the contamination of water sources with usually feces, so excrements of the sick. So once this kind of connection was understood, those who were wealthy and privileged managed to ensure themselves an access to better drinking water and to the sewage system, and kind of protected themselves against the risk of cholera. While with tuberculosis, the story is more contradictory and interesting in that sense, because it was never the disease of the rich, but it was because so many of its victims were poor, but it was also a disease of the rich, meaning that the wealthy were among the victims of this disease, including the members of the imperial family. So Russian Empress Maria Alexandrovna died of tuberculosis. And very much so, it was a disease of the creative people for some reason. So rather like because it was such a widespread disease, and especially among the urban population, it happened that many artists or writers suffered from tuberculosis, which eventually led to a certain romanticization of this disease because also of its symptoms, which is like breathlessness and cough and loss of weight, which made people look more delicate and kind of more romantic in the, especially in the period of the early 19th century. And we could, so there was a certain fashionability connected to this disease. So even some people, we know of accounts where people kind of pretended to have tuberculosis because like it was fashionable to speak blood. But by the end of the 19th century, when its etiology was established and was recognized as an infectious disease, actually we see a slight, at first rather subtle process of stigmatization and of kind of trying to segregate the patients with tuberculosis to special sanatoria, which might be familiar to you through the novel of Thomas Mann, The Magic Mountain. So this is maybe the most famous insight into the life of tuberculosis sanatoria. But still, it is kind of a place where rather privileged people who could afford such sanatoria lived. And then if we take kind of a more contemporary view of tuberculosis, when it re-emerged in the 1980s and especially 1990s, then in, for example, in the United States, and then very much so in the post-Soviet space, it had a completely different sociology and a kind of completely different set of meanings attached to it. It was a disease of the homeless. It was a disease of the drug users and HIV positive people. It was a disease of prisoners, especially so in the post-Soviet space. So we could see how it kind of has this history of being a disease of cultural elites to some extent, to then a disease of really, really marginalized groups. So the third point that I want to make is the relation between disease and expert community of physicians, public health experts, scientists, all those people who claim the right to explain and interpret disease for the general public. There was a great book by a historian of science, Stephen Shapin, who works at Harvard, that has a really unusually long title for an academic book, and the title goes, "Never Pure: Historical Studies of Science as if it was produced by people with bodies situated in time, space, culture, and society, and struggling for credibility and authority." So this is just a title, several lines. So even if we like to think of medical professionals as this kind of altruist people who are sacrificing their lives for the greater good of saving human lives, medicine does not exist in vacuum. And it, of course, reflects and incorporates broader values, attitudes concerning class, race, gender, mental geographies, inequalities of a society, the kind of a big society, but also the smaller universe of that specific institutional medical community, which includes the narrow professional concerns, the distribution of funding and status, the institutional structures and academic training. So this is something that one also has to keep in mind when looking at a disease. Then the fourth point that I want to make is this kind of to emphasize the connection between the social responses to disease and their ability to provoke fear and disgust and other strong emotive responses. So in my own historical work, I see how sometimes really obscure and rather not threatening diseases in terms of incidence and mortality rates receive tremendous public attention, and a lot of money is being spent on preventing them simply because they cause such a strong emotional response. So in my own research, for instance, I discussed a case of a disease probably none of you have heard of. It's called trichinosis, or trichinos or trichinellose in Russian, which is like a tiny parasitic disease that you could get. You get it for tiny parasites like worms that are can be found in undercooked pork. And there were a couple of, like, several hundred cases throughout the several decades of the 19th century. So really nothing compared to tuberculosis or cholera. Yet this disease provoked a huge reform of meat supply, meat inspection, and in many ways shaped food production that we have until today, because people were shocked by this idea of finding tiny worms in the meat that you eat, that you actually don't see them and you don't smell them and you don't taste them, but they are there and you could die when you eat this meat. So this kind of cultural contexts of disease, of the specific symptoms and manifestations of disease, are also not to be disregarded. And of course, what produces such a strong response within one community might not produce it in the other. So the fifth point that I want to make is the connection between the diseases and the broader socio-political discourses of the time, their potential to fuel relevant political debates, to trigger social mobilization, reform and policy change, or political protest and violence. And this is particularly important, why the same disease causing the same symptoms in similar social groups can provoke completely different responses in various communities, or in the same community, but at the different moments in time. So we know that, like, cholera resulted in really dramatic social mobilization and caused riots all over Europe and beyond. So in Russia, as much as well as in Great Britain or Germany. And many aspects of our life that we enjoy very much today, like sewerage system and water supply, a welfare institution, or public health network, was developed historically as a response to cholera. Especially towards the end of the 19th century, when its etiology and its prevention were largely understood, an outbreak of cholera was perceived as a sign of backwardness, and really triggered huge distrust in government. So this happened in Italy, and this happened in Russia also, which was hit by a particularly dramatic epidemic in 1892. So some historians even think that the entire Russian revolutionary era, which, you know, most of us probably associate with 1917 or 1905, actually began with that cholera epidemic, which was kind of the last drop to disrupt the social cohesion in Russian society, and something that triggered the distrust of kind of intellectual elites in the power of imperial regime to ensure the well-being of population. So with tuberculosis, this mobilization is much weaker and comes much later, but you could also see how it feeds and is sometimes instrumentalized for political purposes. So we could see how physicians of imperial Russia used tuberculosis statistics as a metaphor of state neglect and backwardness, and kind of mobilized it to discredit Tsarist regime. But then when this kind of political change happened in a very radical, unexpectedly maybe radical form, Soviet health officials already dealt with tuberculosis as a very powerful symbol, which they then inverted to manifest the success of Soviet science and social policy, which are promoting, health and saving lives amidst the political terror. In late socialism, these declining rates of tuberculosis were used to demonstrate the parity of the Soviet healthcare with its Western alternatives, while then after the end of the Cold War, when the tuberculosis rate started growing, the very same kind of statistics was used to show, on the contrary, the inferiority of the Soviet health system compared to the West. So the same disease is never, it kind of went through various interpretative waves, how every new power was kind of twisting it to fit in their own social and political agenda. And that brings me to my very last point, that it is very important to keep in mind this combination of social, scientific, cultural, political factors when we think about the artistic representations of disease, and why some perhaps triggered more reflection in literature and arts than others. And I hope I imagined it as a little link to what the next speaker, Lera, would be talking about. So just to, if you think of tuberculosis and cholera in context of artistic representation, it is clear that tuberculosis is just so much more prominent and compared to cholera. So we think of the, like there are many literary works that mention it. Well, I already mentioned The Magic Mountain. There are operas where kind of it's one of the key twists of the plot. Why is it so? So there is the biology that I mentioned earlier in my talk plays a role connected to kind of cultural responses and social responses. So tuberculosis is a much more aesthetic disease, or it's a disease that you could play on stage. It is because it's much easier to represent somebody coughing or suffocating on stage, while cholera, despite its tremendous importance for the 19th century history, it's very difficult to integrate it even in a narrative literary account, let alone to put it on stage, because it's a bit, its symptoms were so offensive to the bourgeois sensibilities of the modern era, like vomiting and diarrhea, and it's really difficult to kind of stage it in a way which would be acceptable to the public. Then one could also think of this, not only acceptability, but simply the beauty of tuberculosis, which kind of, as I mentioned, produces these very thin, delicate bodies, breathlessness. The breath, of course, is a metaphor of life, and how it kind of fits very nicely with these artistic representations. And at the same time, people are pale and thin, which often made their eyes appear bigger and kind of visually resulted in a more impressive picture. And while with cholera, this somehow didn't work. And that's why I just, as a historian, I find it rather interesting to see also among my students how some diseases which are so important historically then are completely neglected, because actually historians do not play a major role in shaping their historical memory. And other fields like arts and literature become very important here. And I'm sure we'll hear more about it in the next talk. So these were my 6 points. They are, of course, not exhaustive, but I thought, and I hope they can be a nice introduction into how to approach kind of a social history and social responses to specific diseases, and maybe they can be helpful to think with in this process. Thank you.
Thank you, Anna. And I really hope that COVID-19 pandemic would work as cholera, so that it would lead us to bettering of our condition rather than worsening of them. And I would like to introduce our third participant, Lera Kononchuk. She is an art and cultural critic who lives and works in Moscow. She writes about contemporary art and culture in a number of papers and online editions. Recently, she has been working as a curator of the artistic and theoretical project Practical Affectology Unit, studying the influence of technologies and affective formations and structures of feelings. Please.
Thank you, Andrei. Thank the organizers and you as well for the invitation to take part in this discussion with such outstanding speakers. I will start with a bit of art history on pain and illness, and in particular, in what way pain and illness were communicated through images, if they were at all. Andrei rightly pointed to the virtuality of illness when it doesn't have any visual sign. And then I will expand on phenomenological approach Havi initiated, and I will speak of how pain and suffering become an abstraction and how art deals with this tendency, bringing them back to the singularity of beings and their feelings. Sorry, it may be a bit slower today than actually I expected due to pain. Well, I have a crack in my ribs, so I have difficulties breathing, but I'll try my best not to get over time. Well, first, what is important to bear in mind is that the concept of pain and illness hadn't existed until a relatively recent point in time. Before Enlightenment, pain wasn't actually institutionalized. It wasn't fixed in language and culture. It didn't have its own discourse and order. It didn't have its own image. Actually, I'm going to show you maybe some of the images that I prepared. So this one is something of before Enlightenment. It didn't have an intrinsic value in culture, but was regarded as a medium carrying messages. So it brings pain itself. It brings God's message to Job, or elevates flagellants and martyrs to God as well. That is why the martyrs and flagellants look so enlightened in paintings usually. Christianity, with its cultivation of suffering, served as a prerequisite for the birth of pain as concept. However, a Christian martyr wasn't supposed to indulge themselves in pain and thus be captured by this normal, ordinary life. In paintings right up to the Baroque period, nobody cried from pain, since it wasn't problematized as a concept. And well, the punishment of the martyrs kind of undergone consisted in just humiliation or destruction, but not in inflicting pain to them itself. So up until the 16th or 17th century, illness or pain had only a functional meaning, usually a very symbolic one. So that's why in the history of European culture, we have passions of the Christ, but not suffering or pain, actually. Well, this meaning of pain or illness as symbolic representation of something else lingers on in culture, which Susan Sontag wrote extensively about in her Illness as Metaphor, where she speaks of mythology around tuberculosis or cancer, which in common imaginary didn't stand for themselves, but was still seen as a punishment for one's sins or an expression of hidden passions. For instance, Freud's mouth cancer was regarded to come from his dissatisfaction from his sexual life. And we clearly see that viruses and epidemics are now metaphors for something else, for the threat of the other, internal enemies, or virus can be just seen as a symbol of change or globalization and its vices. But if we take that pain in itself was absent from art before the Baroque period, it comes with the antique images full of suffering, where pain is legitimized and evokes, obviously, compassion and empathy. Then also the medical discourse develops. And if we take a look at the paintings of that time and later, the patient is usually lying like a doll, senseless. And because there was a tacit and unconscious ban on depicting suffering, for example, during surgeries. This picture is not a surgery, this is a punishment actually. And when there were depictions of punishments, there were accent on tools, on performance of justice, or just on the act of justice itself, on its aspects. While the criminals weren't supposed to look like they were in pain, so as not to evoke compassion. So there still wasn't any context around pain or illness, and only during the Enlightenment period, after the body pain acquired its autonomous existence as a medical concept, did it get its own validity. And of course, the whole background associated with it was brought forth, the one of darkness and terror. Well, Hegel considered the depiction of the disgusting bodily suffering and torture as inappropriate, since for him, for Hegel, the content of a painting must be the life of the spirit, its suffering of love, not bodily suffering. So the dark aspect of body suffering only became interesting for the Romantics. In the second half of the 18th century and beginning of 19th century, the artistic reflection of Christian religious art shifts its focus to a deformed and ill-looking body. While Schiller, for example, discusses this conflicted relations between aesthetic beauty and moral goodness and sees this connection between them, between beauty and moral goodness. This connection seems to lose its hold in the works of further thinkers, such as Diderot, for example, who denounced the idea of an ideal of beauty as a construct that doesn't have any equivalent in nature. Well, to be fair, Schlegel was an advocate of classical art and regretted the inrush of the deformed and the ugly in the modern period. So he denounced it, but from time to time, Schlegel lets out a spark of admiration before the art of his times, the ugliness, the deformity that comes with it, the art of his times, and hopes that it carries principles that would allow to break existing barriers between the ugly and the beautiful. And in the art of his time, Schlegel sees the dominance of the interesting over the beautiful and of the specific and individual over the ideal typification that was characteristic for classical art. So Schlegel reminds us that the interesting and the specific need the deformed and imperfect in order to keep us in this constant state of excitement. Another romantic author, philosopher, novelist, too, was very keen on nihilistic and sentimental idea of the interesting, saying that the ideal of absolute health is interesting only from the scientific point of view. What is really interesting is the illness that corresponds with the individuality. Later on, the ugly becomes an integral part of the beautiful, which the artistic fantasy would have to consider. For example, Karl Rosenkranz in his Aesthetic of Ugliness, it was written in 1853, 4 years before Baudelaire's Fleur du Mal. He develops a phenomenology that begins with a description of the wrong and the imperfect and ends with a description of disgusting. For example, he describes the abominable symptoms of syphilis. He comments on a painting by Jean-Antoine Gros, Bonaparte in a plague hospital, visiting plague hospital, where he unwittingly admires the plague bubbles, the beautiful depiction of which required, of course, a certain heroism from the part of the artist. And Rosenkranz recalls that a disease is ugly when it causes deformities in bones and muscles, or colors the skin like jaundice, желтуха does. But it is almost beautiful in the case of consumption or fever, when the disease gives the whole body an unearthly spirituality. That's what Anna was speaking about. He even claims that a truly bright sight is a girl or young man affected by consumption on their deathbed. So disease in painting has an appealing power, both when the artist idealizingly paints the fading of beauty in a weary body on the threshold of death, or the slow flow of the disease, and when they realistically portray the outcasts of society weakened by so-called illnesses called old age or poverty. And in the post-romantic period, this representation of pain, illness, and suffering is mostly connected with pure aestheticization of the horrible and tackles art's internal problems. Decadents like Guzman's, Baudelaire, and Rimbaud were already wallowing in this exquisite pleasure of suffering, celebration of neurotic conditions. Proust wrote how attractive the majestic aristocracy of ugliness is. But in the 20th century, the ugliness acquires an attribute of resistance. Futurists and Dadaists saw suffering as an antidote from superfluous sensitivity and soppy bourgeois sentimentality. Adorno wrote of surrealists and expressionist depiction of the ugly and the deformed as a refusal to live according to the norms of beautiful life of the deformed society. And thus, of course, the art was sometimes bitter and resentful. And Adorno regarded art as something that also had to make its case what is outlawed as the ugly, but not to integrate the ugly, soften it, and reconcile people with its existence using humor, for example, like Hogarth did, but to stigmatize the world, which creates and reproduces the ugliness in its image. So art accuses the power and provides evidence of what this power displaces and rejects. So what certainly attracts artists in images of pain and disease, injuries, deformation, prosthetics, and bodily fluids is this tension between seen and hidden forces, virtual and actual, as Andrey pointed out at the very beginning. So artists have always had this keen interest in something that is suppressed and what is subjected to the mechanisms of exclusion. That's what basically what Deleuze writes of Bacon's paintings. According to the French thinker, Bacon made explicit the invisible forces of deformation, the forces of pressure, tension, squeezing, flattening on an immobile head. So the body adopts positions as a response to a simple force acting upon it, the desire to sleep or to turn or to laugh, for example, as in this painting, nausea, etc. At that, the body shouts. So, you know, a lot of paintings by Bacon where there's a shouting mouth. It shouts toward death, but death is not something too visible that disempowers us. On the contrary, it is an invisible force that the life catches, shows with a shout. And from the point of view of life, death is doomed. And by depicting terror, injury, prosthesis, failure, just as Beckett and Kafka did, Bacon creates figures that are invincible in their persistency, in their presence. So movement is usually distilled to a spasm, which points exactly at this action of invisible forces upon a body. One of the most, to me, excruciating portraits of the visibility, invisibility of illness is a film called Order or L'Ordre by Jean-Daniel Paulet. It provides an insight into life of the leper colony on an island of Crete through the eyes of a man who tells the story of his life to the camera after having been excluded from his community to spend years of his life on the island with his fellow sufferers. When you recover from leper, he states, you are still sick. Even when there is no trace of the disease, leper stays with you and you stay in prison. But what we see in this film is that beautiful island landscapes, lots of them, unmarked by death. So the question hangs in the air. The question he asks, do you think death becomes contagious when it is seen? And in the medicalized contemporary society, pain and illness are regarded as something to overcome, to fight, and to destroy, to isolate, to make them unseen, first and foremost. And the body is more and more rationalized, anesthetized, and sterilized. Well, actually, pain killing didn't used to be the main ambition of medicine. Well, death could liberate one from pain, but the insensitivity of leprosy skin was well known, and the dying of limbs associated with it was a warning against the desire for painlessness. Modern medicine, on the other hand, is primarily focused on eliminating pain, and behind this statement of the problem is evident the desire to distance ourselves from suffering. Life without pain doesn't seem to be just ambition today, it's already a reality. We are today pushed to using pharmaceutical methods of eliminating pain in all cases. And at that, pain killing or anesthetizing do not lead to the reduction of suffering. On the contrary, they also might strip us of ways of dealing with pain when the pain actually occurs. So the subjects seek access to their own bodies and feelings and try to find ways of making sense of their painful experience. And what they do is they try to figure out alternative ways to the medical ones of producing knowledge. Well, Petra Coopers in her book on medical performance provides a very valuable example of contrasting two kinds of visual projects. The first is a large exhibition called Corpor Welten, in English it's Body Worlds, hosted by museums in several countries around the world. This exhibition was created by medical doctor and researcher Gunther Verhagens and brought into public forum plastinated human corpses, dead men and women who were skinned, anatomized and posed. Well, they had previously agreed to have their bodies completely preserved after death. And the exhibition intended to teach through art. So it wished to show the workings of the human body by making it as available as possible to the gaze. Well, of course, it resembles, you might have heard of them, the anatomic Venuses of the 19th century, female bodies on which medical students studied anatomy. However, apart from the fact that this exhibition was kind of dehumanizing and objectifying and blatantly spectacular, well, this dried plastic, according to Coopers, didn't speak. It pointed to an absence. This body, plasticized and colored, drained and dry, odor-free, was to be rendered readable. So what is missing, this two of the experiences Christopher discusses, blood and pus and body fluid shit. So the flesh lost its opaque singularity, and the general body existing within the realm of signified death became abstract like a map. And to get away from this, well, first I need to say that Coopers herself was very interested in this exhibition and interested in the image of the knee, but they were of no interest to her, these exhibits, because they didn't present as parts of a complex social, cultural, and biological network. The whole exhibition was more like a spectacle, which could give only, which could only give the thrill of horror, death, and gore, while also constructing a medical vision of wholeness, and the ability to see, to order, and to structure. So to get away from this educational exhibition, the drive towards abstraction, and this is my point, is omnipresent today. So this multiplication of images of pain, suffering, and illnesses work as a visual vaccine and make pain more abstract. So pain loses its concrete meaning. And it is always there. It's not attached to a concrete body, but as a result, it is abstracted as a medicalized, pharmacologized unit. So speaking of technologies, it's not only pharma that numbs, but media as well. And here we have a thesis of Susan Sontag, who, following obviously Walter Benjamin, speaks of mediatization that relieves pain. So she stipulates that this overabundance of pictures of war, destructions, and suffering leads to a chronic voyeuristic attitude to the world that leads to passivity and numbing of all senses. But what is interesting yet is that numbing doesn't mean the total relief of pain. The pain, I think, stays there. It's just abstracted and thus always present in a manner of a constant low-key pressure. So probably that could be an explanation for the predominance of somatoform disorders today, which is constant pains that are not clinically apparent. So what could be contrasted to the exhibition Corporal Welton are contemporaneous visual experiments that haven't clarity but opacity as their generative principle. The undecidability that can set up a desire to know from our side. For example, there is this project, video installation by Shimon Etty called White Nights, Sugar Dreams, which spoke to personal experience of diabetes and was focused on the passing of personal bodily time. So in the installation room, quiet voices speak to the visitor of images and feelings that emerge from living with diabetes. The video doesn't show interviewees, but present the viewer with the kind of changing landscape. A red liquid changes texture and color as white crystals fall into it. So there, red stands for blood, of course, and white stands for sugar. So the work deals with this fantasy component of physicality with associations, visualizations, and images that surround the experience of diabetes more than anything else. And moreover, it's a community creation. Multiple voices speak about their lives. So the installation gives body to some of these fantasies and opens up new ways around the dominant narrative of diabetes and escapes explanatory materials provided by doctors and circulated within popular knowledges of bodily functioning. Maybe one of the well-known, I'll skip one, but maybe one of the well-known cinematic rendering of such alternative knowledge production of a disease going against medical reference point as well as popular cultural dissemination is of course Blue by Derek Jarman, which was revealed just several months before his death from AIDS-related complications. These complications had already rendered him partially blind at the time, and he was only able to see shades of blue. AIDS back then in the early 90s was accompanied by mass hysteria. What was part of the epistemological apparatus back then is the scientific visual certainty of normal and formal material, foreign material. And they became these fetishistic objects in the late 80s, providing metaphor for AIDS and requiring this identification of this invaders and evil spies. It was the rise of microscopic and diagrammatic visualization systems that show this evil invaders in an infected body, probably for the first time in such a mass way. Plus, HIV virus was said to function as a copy machine whose host cells were dressing up. So in other words, the AIDS-causing virus method was said to be kind of working like drag. And of course, this all correlated with this hystericized gender scene of the 1980s, where drag communicated gay plague, dressing up as women, undermining of heterosexual male singularity, evil insider who boosts moral decay in a healthy society. And against this scientific and mass culture epistemological background, Jarman, gay himself, he rejects the grammar of cinematic language, resorting to just monochrome blue screen accompanied by a narrative drawn from his very, as you probably know, intimate diaries, sound effects and music, which all attempted to convey this complicated mental, physical and emotional strain caused by his terminal illness. And Jarman's sensory impairment also comes to mirror that cultural blindness surrounding this desired closeting of gay sexuality and the suffering of those caught up within the epidemic. Well, and apart from that, I approach my final point. German Blue reveals the limitations of language, both spoken and visual, to effectively articulate suffering and pain. He turns to these complexities of color in an attempt to express, to make sense of the senseless loss and tumultuous emotions that punctuated these decades. So there is no binary antagonistic relations between health and illness in his film. Rather, Jarman virtually presents his life under a different shade, showing us how this shade, how this particular color produces transversality of sensation, sewing together vision, touch, hearing, and affect, bringing bodies and affects together to rupture the constricting structures of this sensations and medium. And I would also like to touch upon the problem of this communicability of pain and what it has to do with the image. Well, physical pain may not only resist language, but actively destroy it, as Ellen Scarry observed. At the heart of pain and suffering is that opacity and incommunicability that somehow escapes communication and meaning, yet it repeatedly excites both discourse and practice. Because, well, obviously it's well known that throughout art history, there have been many examples of artists struggling to capture and to narrate this ineffable instant when the body is hurt and the awareness of pain on the part of the suffering subject is revealed. But what interests me in our, or maybe current situation of coronavirus, to get most actual, is that the suffering subject is absent from the picture. The body in pain must be constructed, right? So it must be imagined and interpreted on the part of the viewer. But what we only confront now mostly is that reductionist, minimalist aesthetics. So it's been around 9 months with the COVID-19 here in Russia, at least. Still, the dominant narrative is that of absence. By minimal aesthetics, I mean, well, empty streets, closed spaces, shiny sanitized surfaces, patterns like, you know, people queuing at 1.5 meters distance from each other, as well as the grid, by which I mean Zoom grid, which with all its sound inconveniences and connection failures points to the absence of lingering presence of other bodies. So coronavirus is abstracted to the point of becoming a metaphor of globalization, although the experience of it is hardly communicable, not only because pain is immeasurable, unpronounceable, and unrelatable, as Wittgenstein insisted. After all, many artists prove that imagination stands as this emergency measure, providing an image to a state of consciousness. And in this way, they make an abstract experience embodied, singularized, concrete, and communicable. The experience of coronavirus is hardly communicable because the body itself is hidden, anesthetized, and is driven to abstraction. So although there are many vulnerable bodies out there in the street, the dominant idea is that our body is a minimalist body, a shiny stainless steel cube behind an interface. At the same time, as I have already mentioned, with the pain and suffering abstracted, they are always present as a potentiality, and we are far more sensitive and vulnerable now than in any previous period. So for me, it would be particularly interesting to see how artists are going to work with this situation. Well, there were, final shot, there was attempts to visualize the virus itself when it all started, including a cheeky game by Mikhail Maximov called Modern Art Massacre, or something like this. Actually, I haven't checked, but something like this, which added kind of a light, humorous touch to this catastrophic discourse of the epidemics, shutting down the museum and biennales, as well as it provided like a spatialization to a flat news feed concerning coronavirus. There were special representations of the virus itself in cages, and you could like shoot artworks in different Moscow museums and galleries with a big gun, pretending to be a coronavirus, like return your agency. To a certain extent, Maximov's work was a success as a visualization of a fantasy on the most powerful agent today. But, well, what is invisible actually in our situation, I think, it's not the virus itself, it's not really a problem, but the vulnerable anesthetized body which lost its agency. So what requires attention is again this set of biotechnological connections in which the body, including the suffering body, is involved, and how this complicated connection could be communicated. So that's it with me. I would be really happy to join the common discussion.
Thank you, Lera, and I'm sorry of your week. Hope you would recover soon. So I would like to maybe catch your last idea of your presentation about non-communicability of this experience or virus, and maybe to address this experience or virus to Javi to open up discussion between participants, and probably what I would say would also relate to Anna somehow. So Javi, are you here? Because I do not see.
Yes, yes, of course.
Yeah, good. What I've seen before the pandemic, it was common. I mean, if you're not, for instance, a disability activist or another kind of activist, or maybe an artist or writer, so your personal experience of health would remain somehow hidden in like intimate domain. And of course, it depends on the culture. Like we have a discussion with Aaron Schuster, who is a cultural critic, and he pointed to this distinction, like in Slavic countries and in Russia, people do not say that much about their, they would like complain about the state of health. So like if you ask me, how do you feel? Oh, I had insomnia, I feel so bad today. And if you ask an American person, they would say, oh, I feel feeling so good, I'm feeling great now. I mean, it's a stupid generalization, but it makes sense anyway. But anyway, it's like some cultural differences, but still in general, when the pandemic came, people started, firstly, maybe celebrities and some bloggers started to write with first people who catch this virus about how do they feel, what they experience. And then now on the second wave, if it is a second wave, I feel that everyone started to, well, when it became an absolutely mundane experience, I have a personal feeling that all my friends ill now, you know, so it really affected mass population. And people continue to write about how they feel, how they experience ill, do they feel taste, do they feel that, and so on. And they make this COVID diaries on Instagram, on Facebook, and different social medias. And I'm interested in how this phenomenological or subjective experience of illness transforms when it implies that it will be published online and will address many people and not like only yourself or like your family members or close friends. So maybe you have any thoughts about that. And also maybe it relates to Anna to more social and political domain of illness rather than being a phenomenological experience.
Yes, thank you very much. Oh, sorry, Anna, did you want to?
No, please go on. I can wait.
Okay. I think the pandemic is a fascinating case. I think what you're pointing to, the question of how to document, who to share with, and nowadays, obviously, sharing is so much more prominent on people's minds. I think those are really key issues when we think about representations of illness. I mean, with the pandemic, what is particular about it is I think it's very, very unique in that obviously not everybody got sick at the same time, but everybody faced the threat of the virus at the same time, roughly, you know, within a few months of each other. So it's a pandemic, and so the whole world is involved in this. And that means that the experience is not just shared, but I think more strongly it's collective. I think we are experiencing something that cuts across, cultures, languages, geographical locations in a way that's very, very unique, but at the same time also is punctuated by huge differences in the way in which the pandemic has been received, understood, processed, and experienced by a lot of by different cultures. And I think the previous talk raised a few times the issue of stigma and health inequities. And what we're really seeing in the pandemic is how health inequities are playing themselves out, both in the way that people experience the pandemic, whether they're sick or not, but also in the way in which they record and communicate those experiences.
May I jump in? Yes, I also wanted to, I totally agree with you that this Corona diaries and kind of reflecting on your individual experience of illness became really, really widespread. At the same time, I want to add that it's not only the experience of illness, meaning your own individual experience of being sick, but it's also an experience of disease as a social phenomenon. So at this kind of Corona diaries, they didn't cover only, so it's not only people who were actually sick who started documenting their life and sharing it with everyone, but it's actually people who were not sick, but who felt affected by this disease in some way. So even at my former employer at the University of Munich, we had an institutional Corona diaries where people who, it was really called also that way, Corona diaries, where people filled every day actually their reflection on how this whole pandemic affects their life. So it is maybe a little bit brings up this kind of tension between disease as a social phenomenon and illness as an individual experience, which maybe we could also reflect a bit more on our discussion. And so this kind of accounts, personalized accounts proliferate. And in the historical community, there was, of course, a big interest, I mean, historians of medicine also specifically, big interest to the current pandemic. And like the first kind of reaction was, well, we have seen it all, this is like in that epidemic, or we have seen that already, the rise of conspiracy theories, the social protest, like we've seen it with the past epidemics. But when we asked ourselves a question like, what is radically new about this pandemic, something that we have not seen before? And I think the answer that emerged was the medialization. So this level of media activity, thanks to social networks, thanks to the internet, this is something that previous pandemics did not have, and that it became possible to share your personal experiences or any type of disease-related information, and also get active and get together and take measures and mobilize through, or like having a Corona app, where it's a big thing in Germany, like that you have this app on your phone where you could, if you have your Bluetooth on, you could trace your contacts and you upload your test results. So all this mechanisms which are just not available for previous generation. But I see, and like referring to what Andrey said, that this kind of media sphere that we have also affects the way we produce our individualized accounts of both the illness and the social side of the disease.
I wanted also to raise, again, one issue around coronavirus. I think it's unavoidable in a way. Something that Javi just mentioned about inequality in terms of access to medicine. When the pandemic started, I have a stupid example. Maybe I saw a video by Madonna, the singer, who was, maybe you saw it as well, it was published on her Instagram page and then was widely disseminated. She was lying naked in a bus, covered with rose leaves somewhere in her mansion. I guess she lives in Lisbon, I don't know. So basically, and she was talking to the camera about how this virus is, how dangerous it is, and that it affects all people. And she uses even this word, great equalizer. It affects all people, funny and no, poor and rich, everybody. And she says that I'm really scared that it equalizes people, basically. That's her claim. She doesn't say black and white, gay, straight, whatever. She just meant, I think she meant it. So what I wanted to say, of course, it's kind of hypercritical example. And now, what I see myself, that people become more suspicious about this virus, in like not only in terms of conspiracy theories, but people write more and more about medical conditions, because you see all these celebrities and political establishment like Donald Trump, Prince Charles, Boris Johnson, and some other people like Russian vice president, who they all had coronavirus, but they didn't die. They didn't have any consequences. And at the same time, we have this 1.5 million people who died from it that don't have names. And so people really feel, as I see, that it's not a matter of biology merely. Yes, it's not that we are all equal as bodies, but it is a matter of our access to certain lifestyles and to certain medical health care. So I would like to ask you, Anna, maybe, and other participants, if you also want to say somehow this understanding of inequality maybe evolves nowadays.
Well, of course, I think you're totally right to highlight this relation between the current pandemic and the inequalities in our society. So I don't think people who actually seriously deal with disease think about it as a great equalizer, because especially in the US, for instance, it's very clear how the Black community was disproportionately affected by the coronavirus. And that we also, so inequality, social status is not only one aspect. So biologically, we could also think of the age. So we know very well that coronavirus is more dangerous for the old. And so then the younger you are, the easier it is. And it is in the societies like in Western Europe, where you have a relatively old societies, where a higher proportion of society is, say, past the retirement age. So there are also these discussions, or, you know, why are we sacrificing the young for the old? And so we are losing jobs to keep this old people over 80 alive. So this kind of social inequalities, they are also there in the discourse, you know, maybe sometimes on the periphery, but they are very important. Of course, access to healthcare is a very important part of it, especially, say, in the US, where we know health insurance is a highly politicized issue, and there is no universal health insurance. So this is kind of somewhat a different situation than the one, for instance, people are used to in Germany or Austria, where I work, where it kind of more or less everybody is covered. It affects both how you experience disease itself. So let's say through access to adequate hospital, the access to artificial lung ventilation and so on. But it also affects, for this kind of social inequality, affects your chances of getting the disease. So there was a lot of interest to the work of professions which were then, during the first lockdown especially, conceived as indispensable. So like nurses, carers at old people's homes, or people who work in the shops, or couriers. So all all the people who could not go into home office and who had to go and be exposed to increased risk of getting the virus. So this is all the context in which kind of this social inequality came up. Access to healthcare. If you get the disease, the difference in risks of getting the disease depending on your profession and social status, then we could also think of simply how you experienced the pandemic itself, even if you didn't get the disease, but simply the quarantine or isolation. So obviously it makes a huge difference whether you are isolating yourself in a villa with a swimming pool and a garden, or you're a family of 5 living in a 2-room apartment with 1 laptop, and all of you have to homeschool and work from home. And we are not even speaking about the most dramatic cases of people living in the slums. So in the US, for instance, there was suddenly a huge realization how many people depended on the food stamps. So like actually or on hot meals at school. So suddenly, if you are not going to school, you're not getting this free meal. And in a way, like there is this big saying that epidemics are big revealers, which is so visible with the current pandemic, that suddenly the issues which were kind of not in the maybe spotlight of a public attention became very visible because of the epidemic. So in Germany, where I survived the first lockdown, suddenly people realized how important the migrant workers are to the German agriculture, because when the borders closed and people were not coming, then we realized there is nobody to harvest Bavarian espargos or Bavarian strawberries, because these are all Romanians and Bulgarians who come and do it. Or suddenly that there were all the parts of our cars for BMW are produced in China, and they are not coming. So this kind of connections of the global world were revealed. But then other aspects like the conditions of slaughterhouse workers, because there are a number of cases coming from the slaughterhouses. I feel that I'm actually would be curious to hear how you perceived it in Russia, or wherever you survived, wherever you were during the first lockdown. So which kind of aspects of complex social inequalities they kind of entered the discourse thanks to the epidemic?
I personally felt that it's kind of that there is not only 2 opportunities like socialism or capitalism, but also we can see also about feudalism, because it became a real kind of division of labor-based on people who work with their heads, like who work universities, who can teach, who can write, who can paint, or whatever, and people who are couriers and who just basically use not even their capacity to labor, but basically their capacity to move, and who go from one flat to another flat with food. So, and I imagine like a society divided really into groups of people, these couriers and people who live in their apartments. But I hope the pandemic would soon end, so it would never happen. But still, yeah, Lera, maybe you want to say something on that? I also have a question for your presentation.
Yeah, well, I need to say that I have, well, since we are both based in Moscow, I had very similar impression first, because there was kind of an influx of papers and articles on how brilliant it is to be finally shut down from all the world and finish your degree paper or something like this, because you're kind of closed away from the outer world. And there was such a after the first like the anxiety wave, there was so many this positive accounts of being closed, and there was such a revolting tendency, because obviously there was lots of critique afterwards of that attitude. And in terms of artistic representation, what I kind of wanted to criticize too is that the first maybe half a dozen of exhibitions and projects dedicated to the experience of pandemics were solely dedicated to this experience of this healthy body forced to this isolation, and not about this vulnerable bodies outside who have to go from one flat to another and, you know, expose oneself to the virus and probably get sick and, well, who knows whether to recover or not. So it was like an isolationism of the privileged going on, well, with the first reaction. Well, of course, everybody kind of jumps out of their own experience. So that was a real, you know, kind of a real show of how actually privileged artists all over the world are, basically. And but of course now the whole discourse is a bit more diverse. So now we really need to, well, I had also a point about your first question, Andrei. And I think that, well, that's interesting about the communicability of pain and the whole like media hullabaloo about well, sharing the experience of pain. I stumble across messages like, I don't think that anyone experienced something that I experienced, and they kind of list down their symptoms and so on. So although we are in common, so we share this experience of a coronavirus, everybody, because they're not experiencing the exact pain of the other, and just mostly seeing words or just the grid of the Zoom, they take their own experience of pain as being extraordinary. Well, and maybe it doesn't concern only the coronavirus, but it concerns all kinds of pain. Well, that it's incommunicable after all. But still, I guess that we don't have that cultural representations and ways, maybe good ways, well, of dealing with it, or sharing that experience, apart from just making diaries and stuff. So diaries aren't enough, well, probably. Well, that's my view.
Okay, and maybe, yes, maybe we're having just 15 or less, maybe 10 minutes left. Maybe we can say something also coming back to art. And I also had a question for you, Lera. Like there is a clear tendency in, there is a tendency in medicine, maybe I'm not correct, please correct me, that all the diseases, they became, at least in the second half of the 20th century and the 21st century, less visibly manifested, less vivid, not only because people are kept in hospitals or morgues or whatever, but also we didn't have that many diseases that affect body, like leprosy or plague or some other disease before, except maybe for Ebola. And also there is the same tendency in contemporary art. So we had Expressionism, we had London School, you mentioned Francis Bacon tonight, we had maybe Art Brut is a bright example of how artistic painterly means help you to express these changes and transformation in bodies. But at the same time, minimalist aesthetics, they impose the certain primary structures that are absolutely senseless, sanitized in a way, which and it as if it doesn't have anything, sensible in them. But at the same time, in the 90s, there was a trend called political minimal, when these minimalist forms were endowed back with very direct and very strong political messages. For instance, Felix González Torres, who made works in this trend, speaking about his experience of AIDS, as he lost his partner, and so on and so on. So I don't know if it's correct to put this co-evolution in this way, medicine and art together. Maybe it's wrong and bullshit. Maybe you could say something, what you think about.
Well, that's interesting. I guess that there is, well, I don't know whether there is a correlation of, as you said, hiding something, because after all, minimalism was followed by like post-minimalist aesthetics, and they were all about, you know, gore and terror and body fluids and everything. And now, well, nobody, it's like we have this tendency of coexistence of this two trends. And what I like is actually reappropriation of minimalist aesthetics by those who are more interested more interested in the carnal. Like today we have kind of reappropriation of minimalism by transgender studies, for example. So there is this book by David Gatsby who talks on the abstract bodies and abstract sculpture, well, including minimalists like Dan Flevin's fluorescent lights. And he speaks of it not just as of in a reduction of forms, but as playing with a fluidity, with playing how different, how extraordinary, how unconventional bodies could be. So even when looking back at the minimalist aesthetics, you could just reappropriate it, reread it as what you kind of feel would be most relevant today. And I guess, well, lots of researchers were pointing out that after this period of kind of forced minimalism of forms, what is expecting us is that, you know, vibrancy of color and the desire for the grease. So that after this minimalist period, we would just dive into, you know, hugging and, you know, exchanging germs and so on and so forth. Well, it's probably unlikely, but still there is a kind of turn to that prospects of the future interactions.
Can I also say a word about not about the aesthetic part, I'm really incompetent in that, but this medical and medical historical aspect that you mentioned before. So I feel that there is a kind of a divorce between wider public visions and possibly then artistic visions also on the one hand, and on the other hand, really medical and medical historical discourse about this kind of infections and epidemics. So indeed, there was this period when we all thought that kind of infections and disease is a thing of the past, but it probably was over in the medical community by the late 1880s and maybe 1980s and 1990s with the rise of HIV/AIDS. And the rise of multi-drug resistant bacteria, the return of tuberculosis, the return of some diseases that we actually thought we have kind of conquered, and they are not a threat anymore. So there is a kind of in the even in the history of medicine courses, there is like usually a class, you know, the return of the uncertainty. So it's already a recognized enough pattern that it made it into history of medicine textbooks. So kind of by the late 20th century, the beginning of the 21st century, there is a growing realization that actually we have not mastered the world of infection, and there is a growing interest in the so-called emerging diseases or re-emerging diseases, so those, you know, the coming plague, so that actually we are not so powerful as humans, and that especially in connections between kind of medical studies and environmental studies, there is also very productive interaction, which, you know, to put it simply, says that humans have transformed the planet to such an extent and interact with each other to such an extent that they serve as really, really powerful amplifiers for any infection that's emerging. And we are now living in the era of a pandemic. So this is, you know, we should kind of mentally prepare ourselves that this is not the last one in our memory. So rather, I would feel this is a kind of a feeling in the community of medical and so researchers, or so like medical humanities, to I feel that actually maybe we're not communicating this urgency well enough to the broader public.
Yeah, I mean, it's very crude generalization, of course. I know that plague still exists and so on. Javi, do you want to relate to some things we were discussing? Because we have a few minutes left.
Yeah, I mean, first of all, it's been really interesting listening to Anna and Lera, the different perspectives and yours across disciplines and, you know, countries. It's really interesting. I mean, just going back to this theme of inequality, separateness, the people who were ill versus the people who never got ill, the people who are at risk and the ones who are not at risk. I mean, I think in a very real sense, just what Anna was saying, that this might be only the first of many pandemics to come. I think the theme of vulnerability is absolutely key because yes, not everybody is ill and not everybody is equally ill. But I think the pandemic has given people a sense of, you know, a shared fate, if you like, or a shared interest in the sense that when something like this happens, we're all vulnerable to an extent. And so, you know, perhaps in an optimistic note, we can think maybe this will lead people to greater cooperation or collaboration, you know, an increased recognition of the WHO, for example. But of course, you know, the battle continues between the optimists and the pessimists, or the misanthropes and the philanthropes, saying, with the negative side saying, no, we've seen terrible expressions of selfishness. You know, in the UK, there was people, you know, fighting over pasta packs in the supermarket in the beginning, versus the people saying, no, this is the opportunity for the rebirth of altruism, of collectivism, of recognition of the people who make life possible for the rest of us. So, you know, expressions of gratitude towards health workers, but also people who work in sanitation, school teachers, and so on. So it's interesting. I mean, I think what it has done, I don't know if the optimists or the pessimists are more correct, but what it has done, it's definitely amplified and magnified problems where there were some. So where there is poverty and ignorance or other issues, I mean, domestic violence has been one that was spoken about a lot, or children with additional needs who couldn't attend school, or and so on. Where there were problems, these were amplified and exposed even more by the pandemic. So maybe, you know, that's an opportunity for a clear reflection on, you know, on how we live, on the social structures that give rise to inequality, and for other things, you know, for example, you know, an opportunity for us to hit the pause button on the environmental disaster, you know, the climate catastrophe that's unfolding. So, I mean, one thing's for sure is that there will be plenty more to say. I mean, even if the vaccine is rolled out and it's all, you know, we're all on the path back to normality within a few months, I think this has still been a you know, an earthquake for humanity as a whole in ways that will need to be studied a lot more.
Thank you. I think it's a very good point to end. And I would like to thank all our participants tonight, Anna, Javi, and Lera. And because it's our last discussion in this cycle, I would like to express gratitude to the Biennale team, for Young Biennale, Moscow Biennale for Young Art, especially for the opportunity to be critical to it, which is rare and valuable. And also I would like to express my gratitude to all people who made these events possible. Irina Saminskaya, Daria Leshenko, Philip Smirnov, Ildarий Kubov, Lia Bralidze, and Nadezhda Lebedeva, who were our translators. So thank you, everyone, and stay safe.
Thank you.
Thank you.
Bye.
Very much, Andrei, and the other speakers.